we go. All right, and we can get started. I like how you guys are figuring out how to use the chat. That's terrific. I think that's a really nice feature of Zoom and one that we can take full advantage of. So, well, good morning, everyone. I hope that you're all well on this blustery morning. That wind is really quite something. Oops. So let's go ahead and look at what we're going to cover this morning. We'll do our usual welcomes and introductions, and we'll have some announcements, and we'll talk about the medical portal. And we will follow up, hopefully, on some of our brainstorming cases, the recent one that went across the list, and anyone else that wants to chime in about that. We'll also give you an opportunity to let us know about any new resources you're aware of, any motivational interviewing opportunities, any QI you're working on, anything like that. That's your time, and we encourage you to take full advantage of it. We're really excited to have Dr. Paul Carbone talk with us again this morning. He's come and presented in the past, and hopefully many of you are familiar with him. He's just a really terrific individual and a very, he's expert in his field around autism spectrum disorder. So we look forward to having him talk with us this morning, and then we'll wrap it up by 10. So with that, let's go ahead and do our introductions. So let me see if I can look at who we've got here, and I'll start to go through the list as I see them. I'll start with me. I'm Mindy Tueller, and I manage the Medical Home Portal and the Utah Children's Care Coordination Network. I think most of you guys know me, and I will pass the baton to Athena.
Hi, I'm Athena Parker. I'm also with the Medical Home Portal, and I work with our state partners and also help maintain the Utah Services Directory.
And Cassie Crane. If you're able to unmute, you can also use the chat if that helps. Cassie says no microphone today, but I'm Cassie Crane, and I'm a care coordinator for Wasatch Pediatrics at South Point. Great to have you. Dora.
Hi, hello, good morning. Dora, I'm the Professional Relations Coordinator for Shriners Hospitals for Children in Salt Lake. Thanks for having us.
Glad you're on, Dora. And Evelyn. Evelyn is muted, so she may not be able to talk. Gosh, guys, I wish I could remember all of your affiliations just off the top of my head. I unfortunately can't. So Evelyn, if you have a chance to unmute and pipe in, that's great. Otherwise, if you can throw your information in the chat, that's really helpful too. All right, how about Gina Everett? Gina is also muted. Oh, we got something in the chat. Oh, great. Thanks, Evelyn. Evelyn is a care coordinator at Utah Valley Peds Timpanogos Cherry Tree. Wonderful. All right. And I believe Gina Everett might also be with Utah Valley Peds. How about Gina Money?
Hello, Gina Money, family advocate with Medical Home Portal and UCCCN.
You're apparently in Hawaii or somewhere gorgeous.
I can't see myself, so I apologize for whatever my background is.
Oh, no apologies. It's lovely.
I wish I was there, but no, I'm not.
Okay. Great. All right. Hey, Gwen Anderson, I'm glad you're on the call today, Gwen.
Thank you. I was a little delayed, but I'm glad to be here. And I've appreciated all of the comments on the email that I've received. So I appreciate it.
Great. And Gwen, just remind us who you're with.
Oh, I am with Eric's team with Integrative Services.
Great. Great. Okay. All right. Heidi Bates.
Hi, I'm Heidi Bates. I am QI coach with UPIC.
Terrific. All right. Looks like Ileana is with us. Ileana, are you able to unmute? Ileana is with Southwest Children's.
Hi. Hi, this is Ileana and Janet from Southwest Children's Clinic.
Oh, good. I'm glad Janet's there with you too. We don't see Janet's name show up, but she's with you. So hi,
Yes.
guys.
Hi.
Great. Okay. And we have Jade with us for a minute, I hope. Maybe more.
Hi. Yes, we do have that other meeting at 9, but this is Jade with University Health Plans and Health EU Medicaid.
Glad you're with us for a few.
Thank you.
All right. Janelle Hendrickson.
Hi, I'm from Intermountain Pediatric Care Management. I work at a couple different clinics.
Wonderful. Which clinics do you work in, Janelle?
I have Holiday North and South, and then a few doctors at Altaview.
Wow.
Okay.
Great. Terrific. Thanks. All right. Hey, Jill Connor is with us.
Good morning. I'm Jill Connor, Director of Business Development at Shriners Hospitals for Children here in Salt Lake.
Good morning, Jill. And let's see, I have someone with the last name of Spendlove.
That is me. My name's Jessica Spendlove. I'm an RN with Eric's program. I cover the Tri-County Health area.
Wonderful. Welcome, Jessica. All right. And we've got Kelsey Christopher with us.
Hi, I'm URLN trainee and joining as part of my clinical observations. Thanks for having me.
Welcome. And you're in Montana, is that right?
That's right.
That's great. We're glad you're with us.
Thanks.
All right. And another Kelsey Hamadou.
Hey guys, Kelsey Hamadou here. I am care coordinator for Integrated Services, Eric's team down at San Juan.
Glad you're with us too, Kelsey. All right, Linda Stevenson.
Hi, I'm Linda Stevenson. I'm a care coordinator with Integrated Services in Central Utah.
Wonderful. Good morning, Michelle. You want to say hello?
Good morning. Yeah, I'm Michelle Redfield. I'm the administrative assistant for the medical home portal team.
Great. All right, and Natalie.
Hi, I'm nurse practitioner for Integrated Services Program, and I'm also faculty at the University of Utah. And Eric's tied up in block grant and says he's sorry he can't be with us today.
No problem. I think we're all having more fun than he is. So, all right, Patty Brown.
Hi, sorry about that. I am Patty and I have Brooke with me. We are nurse care managers at the Sugar House Clinic and University of Utah.
Wonderful. Patty and Brooke. Okay, welcome. And Sherilyn.
Sherilyn Hess, RN care manager at Intermountain Pediatrics in American Fork.
Glad you're with us. And let's see, it's Tammy, right, Lambert? Oh, sorry, Tiffany. Thanks. Sorry. Tiffany, care coordinator at Utah Valley Peds Timpanogos office. I should quiz myself later. Glad you're with us, Tiffany. All right, Walt.
Good morning, everybody. This is Walt, Integrated Services Program, and I'm a care coordinator in Salt Lake and also with Eric's group.
Welcome, welcome. All right, and then I'm popping back up to some people I think I missed. So Pat Rowe.
Yeah, can you hear me?
Yes.
Oh, yay! I'm so technology dumb. This is Pat. I'm a pediatric nurse care manager with Select Health Insurance.
Glad you're with us, Pat. And let's see, I think this might be a different Brooke Christensen.
Hi, this is Brooke Christensen. I'm a care coordinator with Utah Valley Pediatrics in Saratoga Springs.
Terrific. Glad you're with us this morning. And Cindy.
Hi, good morning. I'm Cindy Halley. I'm care coordinator for Wasatch Pediatrics in Bountiful and Farmington.
Excellent. Okay. And I think one more is Nikki. If you're able to unmute, Nikki.
I think I got it now. I'm Nikki. I'm a nurse and the care coordinator at Busy Bee Pediatrics in Bountiful.
Terrific. All right. Well, welcome everyone. We're really glad you're here. And let's go ahead and get into our meeting. So yeah, as I keep telling you, sorry, I know you've heard it before, but if you're able to use a computer to experience Zoom, I think that's got the best set of features and you'll have the best experience if you're able to do that. And then we're going to end promptly at 10. I did want to reiterate, we mentioned this last month, just want to reiterate that we are happy to hear that Shriners is collaborating with the University of Utah right now on the Project Echoes for pediatrics. And so there's a couple more this month that are on, let's see, Pediatric Clubfoot, that's today at noon. And then 1 week from today is on-time mobility. So please know that you are always welcome to join those. They are done via Zoom. And I can send out that information again right after this meeting so that you'll have the link to register and to click on. So yeah, we're excited for that collaboration and appreciate Shriners letting us know about that. Jill, is there anything you'd like to say?
Yes, I just want to say thank you for reminding the group. Today's presentation is going to be hosted by Jamie Manning. She is our physician assistant, very intricately involved with our Utah Clubfoot Clinic. Unfortunately, Dr. Hennessy had a very complex surgical case arise today, so Jamie is going to be covering that presentation for us. So yes, please join. They're all have been super informative thus far, so we're really looking forward to that talk today. And thank you.
And Jill, those are recorded and archived for...
Yes, they are recorded and archived. And Mindy, I will go ahead and I will send you a link to the site where the UCCCN members can reach those archived recordings.
Oh, that's great. And you know what, Jill, you're always welcome to put links in the chat as well. That might be a little bit more timely. You can also send them to me by email, but the chat might let people get to that right now.
I will do both.
Okay, very good.
Mindy.
Yeah, you bet. Okay, so we've been trying to do a little bit more of showing you the medical home portal in some of our recent meetings. And so Athena, I'm going to turn the time over to her for just a moment to show you a little bit more about how to find autism related service providers in our services directory. So Athena has done it. Excellent.
All right, great. Well, today, since we have Dr. Carbone coming to talk about Spark, I thought I'd go over just a little bit about how to do some searches within the service directory related to autism. So if I go to the service directory on the medical home portal, there's a couple different ways you could search for things here. I could search for strictly by term. So let's say, for example, I wanted to look up more about Spark after Dr. Carbone's talk today. I could put that right in. You have to spell it right though. And it's going to pull up any listing that has the word Spark in it. So here you can see the Spark for Autism Utah, University of Utah comes to the top. There's also a few others. These just happen to have those words. This one has that word in their email address. So that's why it comes up that way. And we also have the newer map feature here now too. So I could zoom right in on these to look at details about where they're located and go straight to the listing from here. So if you were looking for a specific program, sometimes the key term search is going to be the best way to find it. However, if you didn't have a specific word, you can also do category term searches. So for example, let's say I was just trying to find out about different resources for autism. I could put that in my category term search, and it's going to give me some options here. So here I can see, oh, there is a category specifically for autism programs. let's search that. And within there, it's going to pull up a list of all these different programs. Again, you can zoom in on these if you were looking for something specific in a specific area. Maybe let's say I was going to look at Davis County area. I could zoom in here and kind of get some ideas of what's located here that might have services for autism. Some other words that you might search for category searches could be things like, let's just say you were looking for assessments of some kind, but you weren't sure quite what assessment. Again, if you start to type that word, it's going to give you all of the options of the categories that contain the word assessment. So you've got developmental assessment, educational assessment, neuropsychological assessment, and from there you could refine your search even more. Let's just say, I just want to look at neuropsychological assessments and search those providers. Again, you can see here that you'll be able to locate them by the map. And then finally, once people have gone through evaluation and treatment, you might be looking for resources for therapy. So we do have certain therapy categories that are specific to autism as well, like ABA therapy. So I could, again, do a category search just for that. Or if you were looking for, again, a specific type of program, let's say you knew you wanted to look at like the neurobehavior home program, I could just do a search term for neurobehavior. That might be a little too broad. We'll see what it pulls up here. Oh, that's pretty good, I think. And there's the home program right there. So again, just a few different tips on how to search and narrow your searches down to find providers in your area. Any questions on that?
Thank you, Athena. All right, let's see if I can go back to sharing my screen. Always tricky. Terrific. All right, so let's move to, oh, that's right. I don't want to jump ahead. Tell you about a few updates and new pages that we've got. So we're kind of focusing on our clinical content right now. And we have a new page on, let's see, my camera doesn't seem to be on. Are you guys seeing me?
Nope.
Oh, I don't know what happened. I'm not sure that I can. Let me
see you, but you're frozen.
I'm frozen. That's why my camera isn't on. I hope it's a cute picture. Probably not. My eyes are probably half closed. I'll see if I can turn my camera off for a second and maybe get it to go again. All right, hopefully that's a little bit better. So yeah, we have a new page on care of surgical wounds in children. And we also have a new newborn disorder page on CACT deficiency. And then we've also updated a couple of our diagnosis modules, homocystinuria and galactosemia. So check those out. All right, so brainstorming time. And Gwen, we would love it if you don't mind. I'm going to put you on the spot just for a moment. If you have anything to update us on with that case that you shared, I don't know, a few days ago.
Yeah. So our little guy, we've kind of been up and down. He is 11 and he has epilepsy, severe seizures, autism. He attends the self-contained school here in Price and lives at home with his mom and siblings and his stepfather, and they are becoming homeless. They've had to sell their home, and they actually had an offer on their home and accepted the offer, and then that sped everything up, but then that offer fell through. So that is kind of not good, but maybe can give them a little more time. We did meet, I called Jamie Douglas at DSPD, who was absolutely amazing, and connected me to Mindy Olson, who is fantastic. And what we're trying to do is find a center that has room and that will take him. And we've been told yesterday that one facility had room and would take him. This morning, they're saying they don't have room. So we're hoping to find a place that would has room, then we have to submit all of his behaviors and medical records and IEPs and see if they would think he's a good fit. And Mindy has to go before her DSPD board. He's about 1,200 and something on the list. So hopefully, we can find a place. Mom, of course, would prefer something, in Price, but there is no facility here. But what they did say, Mindy was really great. We had a 3-way call yesterday, and if we find a facility up north, after he's there a year, then they can try to find, like a chrysalis home or a group home that would be closer to where mom and dad are. So we're trying to find a home that will accept him, and then we'll see if he can get approved for it. We've, are hoping that they can find something before they move, and they're hoping, on the next offer, and I'm pretty sure they'll get one. They've already had like 12 people view their home, and if the market is crazy, the problem is they won't be able to find a new home because the market's crazy, and they'll be living in a camper, and so that would not work for this kiddo. So we're really hoping, before the end of the school year, that he could finish out the school year here and then transition. So that's kind of where we're at. So if you have any connections to facilities that work with kiddos and might have room and would be on the DSPD approved list, let me know.
I'm sorry, this is Heidi with UPIC. Did they try Tiny Tots?
We have, that was our first, that's,
okay.
Because of kids, and I think their administrator is out on vacation. So I think that is maybe why we've had such confusion. I talked to them 2 times yesterday, and they said, oh yes, we have room, and then this morning they said, we don't have room,
Bummer. They're
and
great.
So I'm not sure. Becky at Tiny Tots gave me a name of another facility, but I'm not even sure if they're on the DSPD list. So that I'm going to have to call Mindy back and, or start going through the list and see if we can find a place. And where he is so young, that's what's going to be tricky. We don't want him to, be in a facility that doesn't have experience with kiddos. So that's where we're at. So I feel really bad for them, and the poor little mama especially.
That's heartbreaking. It sounds like you did get some good news. So happy to hear that you've been connected to people who sound like they know what to do and care, but it's still really, really difficult.
Yeah, it's a hard situation, but I have to say, Jamie and Mindy have been fantastic, and even doing group calls and texting, and of course mom, we know that she kind of has some trauma, and it's been a super hard decision for her, so it's really hard for her to talk about, and they have done this and are really great at it. So that has been an amazing experience. So that is a positive.
Wow. Okay, thank you so much for the update. And I just want to encourage everyone to utilize that listserv address. That's exactly what it's for. And so we love seeing the utilization between meetings, and we know that you're all out there ready to help. And so it's just terrific. So again, if you have any more thoughts for Gwen, please feel free to reach out to her via that listserv. You're also very welcome to just send questions to me or thoughts to me, and I can move them forward as well. So, okay, does anyone else have a case that they'd like to bring up, or maybe give an update on, or really any of these other things, new resources, experiences that might be valuable for the group, that sort of thing? And you're also very welcome to put your thoughts in the chat. Is anybody doing any sort of motivational interviewing these days, or utilizing that when working with your families? It looks like we've got something in the chat. Okay, bye, Jade. Rebecca. Okay, does anyone have any resources for pediatric dietary classes? Athena, I wonder if we've got anything in the portal around that. I have to say that's probably not something that we have a lot of resources on.
Primary Children's has a adolescent clinic, and part of their care includes a huge, well, I should say a huge portion of nutrition and dietary, but I know there's an age restriction. I believe you have to be 13 and older. Can anyone confirm that?
Okay.
I also know that Select Health, that's just if they're part of the Select Health insurance, but I'm sure other insurances offer it. Kids can go to any nutritionist, just make an appointment for 5 times a year as a benefit, and it doesn't need to be pre-approved or anything like that. So that's an option.
Oh, that's nice.
And if the goal ultimately is like weight loss or, things like that, I've got a couple of providers that I know are in network for us who focus on pediatric weight loss that I'm happy to share.
I'm sorry, this was Heidi again, but how old is the kiddo?
Looks like in the chat, Rebecca says the individual is 13.
Yeah, so actually, I don't know if the dietitian at Sugar House, Susan, can't think of her last name. She has, when I was a care manager, we would send a lot of our adolescents to her because she does help kids. Susan, can't think of her last name. I can see her because I can't think of her last name, but she has helped me on many occasions with kids. But again, insurances probably won't pay for her. I know Primary Children's has, like they said, has a nutrition, and they don't usually charge.
Okay.
And then again, the adolescent clinic, and it is you have to be 13 and older, but I know it's also kind of hard to get into that clinic because it's, I think the wait list is very long.
Okay.
Yeah. Susan, I'll find her and I'll send it in the chat.
Okay, that sounds great. Yeah, there's quite a bit going on in the chat. That's terrific.
Sorry.
No, this is great. So Sherilyn says that Live Well centers at Intermountain facilities have adolescent classes. And Utah Valley actually has one for ages 7 through 17. And it includes a dietitian visit as well as some therapist and exercise classes. And then Cindy also mentions that many counties have dietary classes through extension programs or through the county health department. And then Tiffany says that Revere Health in Utah County has a pediatric dietitian and weight loss provider. Rebecca, where is the adolescent?
We're in Davis County.
Davis County. Okay, well, so we got to go the other direction, but Primary Children's might be an option.
Yeah, I think the pediatrician did a referral to the dietitian at Sugar House already, Heidi, I think, but she wanted her to do like some type of classes like Living Well, but I couldn't find anything. So
yeah, and a lot of times too, because they're kids, it's actually the adults that you have to educate more on.
Yeah.
Because and a lot of the barriers that I ran across was honestly the cost of food. I mean, the good food, healthy food is not cheap, right? And a lot of these parents are on a, so yeah, that's we actually, when I worked at Redwood, we got some adults, the parents into the living well, which helped facilitate down to the kids, but it's hard. That's a tough topic.
Yeah, we did that too. So hopefully it works out then.
Good. Yes. Good.
Okay.
Cindy, did you want to chime in?
So I'm in Davis County, and I was just looking at this for someone through the county extension office. They do have a food and nutrition education program. Right now with COVID, they are, if they can't get enough people to actually have a class, they had just been going into people's homes. I believe Paula Scott is the contact there. The telephone I have number for the county extension is 435-919-1328. I'll put that in the chat. But that might be a way for you to find something for someone in Davis County.
That's fantastic. Great. Okay. Thank you, everyone. One more came in through the chat, and let's try and kind of do it quickly if we can. Evelyn asks, does anyone have resources on toddler support? Evelyn, do you want to expand on that just a little bit? What kind of support? Let's see. Oh, thanks, Cindy. Okay, I'm not seeing more from Evelyn. Oh, there we go. 3-year-old patient having behavioral issues. Primary care provider would like mom to get some support. And Evelyn, where are you located? Where is the 3-year-old generally? Utah Valley Peds in Orem. So Orem area, Utah Valley. Kind of a young patient with behavioral issues. Anyone have any thoughts?
This is Natalie. You could look, I've had really good success with occupational therapists. I don't know, it's hard to find some that, that will work with behavioral feeding problems, but I've had pretty good success. I'll think if I can find one in that area.
Okay, very good. Thanks, everyone. Boy, the chat feature is getting used today. That's awesome. All right, well, I think it's time to shift gears a little bit and turn over to our main portion of the meeting. And so I need to figure out, I think, how to give Dr. Carbone the ability to share. So let me stop sharing for a moment. And Dr. Carbone, feel free to talk and maybe introduce yourself quickly as I figure out how to do this.
Sure. Hi, everyone. It's really nice to be with you all today virtually. And let's see if I can share my screen now for my slides.
I just made you co-host, so.
Okay, can you see that?
Yes.
All right, let me see if I can start these slides. How about that? Is that working? Okay.
Yes.
Great. Thanks for the feedback there. So I think I was asked by members of your group to come and give a quick update on autism, maybe talk a teeny bit about our clinic, the University Developmental Assessment Clinic, and the Child Development Program, a teeny bit about a research study that we're part of in our center called SPARK, and then to make sure I left enough time for chatting at the end. I think I'll try to be done by about 9:45. And I'm not the best, especially as I'm sharing my screen. I can't see the chat, but feel free to put things in the chat, and then I'll make sure and get to those as we go. And this is informal enough. If you have a question that you feel like is more appropriate to just ask, then go for it. But Again, I'm Paul Carbone. I'm a pediatrician at the University of Utah. I've been here now for a good long time, I think about 15 years. And I focused my work on the care of children, adolescents, and young adults with autism. I do that at the Neurobehavior Home Program, which is here at the university, as well as at the Child Development Program. So that's by way of introduction. And let's dive in. So this is just a really brief introductory slide. Autism spectrum disorder, as many of you know, is a neurodevelopmental disability or a difference. That means it's a brain-based condition. The earliest symptoms are often unfold in the second year of life, which is why we pediatricians are important, and pediatric practices are really important in identifying children in the second year of life, generally with screening and surveillance. There's some core symptoms that we'll talk about in the area of social communication, as well as some restrictive and repetitive behaviors that are characteristic of the condition and people who have it. It's generally considered to be lifelong. And the reason why we care is that it affects many children and families in terms of their development and in terms of potentially a lot of caregiver stress that can be mediated by acceptance and supports. You can see the number there. There's a huge cost that's associated with autism that needs an investment from us on a societal level. And we'll talk a little bit about how it was once thought to be kind of rare, and now the prevalence is, as you can see there, is 1.7%, or roughly, rounding up 2% of the population. So it's something that all of us should encounter in our care and interactions with families. If you're more of a visual person, this is the latest criteria for autism using the DSM-5 criteria. It reminds me to mention that there's no diagnostic sort of blood test or neuroimaging test or any other sort of biomarker that's readily available to diagnose autism. So this is a behaviorally defined condition, which means that the diagnosis is based on observations of those characteristics. And they're these days in two main areas: social communication and restrictive repetitive behaviors. It's really more of a social communication condition. So these three domains need to be present, all of them, in order to make the diagnosis. So folks with autism have some challenges in social reciprocity. That's that back and forth social interaction. Nonverbal communication, so things like eye contact, use of gestures to communicate nonverbally, and ultimately having that ability to develop and maintain and understand appropriate relationships, appropriate ways to modulate your behavior in a social way and in a social setting. And then in terms of restrictive or repetitive behaviors, there needs to be at least two of these to make the diagnosis within DSM-5. So stereotyped or repetitive behaviors, some of those are motor movements like hand flapping or body clenching that we sometimes see in clinic, or sometimes it's speech like echolalia. There's usually some insistence, sometimes an intense insistence on sameness and non-functional routines. There may be really narrow and restricted interests. And the latest sort of domain added to the criteria for autism spectrum disorder is some of these sensory processing differences that we see. So maybe being sensory seeking in some modalities and sensory avoidant in others, like being very sensitive to loud noises or tags in your clothes or things of that sort. And then just to speak a teeny bit about prevalence. The current prevalence is estimated by CDC, as I mentioned earlier, is 1.7%, which is essentially 1 in 54. That's done through the Autism and Developmental Disabilities Monitoring Network through CDC. We have a site here at the university. And for every girl identified with autism, 4 boys are identified. This is sort of an interesting area of autism research because most researchers feel that we're under identifying girls and women with autism, and that the ratio should probably be closer to maybe 1 in 3 or 1 in 2. So that's an effort within autism, in the autism community, is to learn how we better identify girls. There has been some progress on disparities in identifying children with autism, in that white and Black children are now identified at about the same rate, which is not the case previously. They're still more likely to be identified than Hispanic children, however. And when you think about children of color, there still are differences in the age of identification of ASD among Black and Hispanic children compared to white children. So there's a lot of work to be done in the area of equity in access to autism diagnostic services that needs to be done. And we're doing some of that work in our clinic. And then lastly, it's worth noting that about 1/3 of children with autism have an intellectual disability, which creates an additional sort of challenge and need for services. So that's a bit about prevalence. And so sometimes people ask, well, how do we get from sort of where when I remember coming to the university and studying autism and thought it would be a bit of a sleepy career, and then all of a sudden, like, there's lots of autism, and I do talks like this like all the time. And it was essentially back to parents. So anything that's happened in autism services or supports usually starts with parents, and autism prevalence is no different. Back in the mid-90s, there was a group of parents in the Brick Township in New Jersey that thought they were seeing an autism cluster. They lived near a river that was very polluted, and they thought that that was causing more autism in their community than was expected. At that time in the 90s, autism was a rare condition, thought to be about 1 in 1,000 in terms of prevalence. And so they convinced a lot of these people that are on this paper that was published in Pediatrics in 2000, who were at the time working at CDC. And they sent these folks down there, and they did some epidemiologic work looking at medical and educational records and tried to estimate the prevalence of autism in the Brick Township. And what they found was that the prevalence was more like 6.7 per 1,000, which is about close to 1 in 150. And so they went scurrying back to the CDC and said, wow, like, either there's an autism cluster happening in the Brick Township, or we've been really underestimating autism throughout the entire United States. That led to the development of the Autism Developmental Disabilities Monitoring Network at CDC, which still exists today. They estimate prevalence every 2 years. And the first data that was reported came out in 2000, shortly after that paper, which launched this effort. And they found that the prevalence was exactly the same as the Brick Township from a group of nationally representative sites, 6.7 per 1,000. So there was nothing really special necessarily going on in the Brick Township. It was really just reflective of the country as a whole. And then what we've seen is these efforts that are epidemiologic in nature have taken place every 2 years. And you can see this sort of, with the exception of between 2010 and 2012, a steady rising of the autism prevalence across the US, and to where we are now at this 1 in 54 number. And so this is probably one of the most common questions I'm asked. It's like, why are we seeing more autism these days? And why is the prevalence increasing? And certainly you can't rule out this possibility that the true risk of developing autism is increasing. That's something that researchers are looking at and are not able to answer completely. But based on some other things that have nothing to do with risk, there are some really practical reasons why the prevalence is increasing. Over the years, we've broadened the criteria for autism, so that brings in more people into the definition. Certainly, there's a lot more awareness around autism amongst medical providers, amongst providers in general, and among the general public. We'd like to think at the American Academy of Pediatrics that universal screening recommendations that are now in place have had something to do with the improved identification of people with autism. And then, of course, there's a lot more services available for people with autism these days. So it makes sense that you would find more of them because you can actually sort of direct them towards services, which is great. So that's some of the reasons why the prevalence is increasing. If we look at sort of what causes autism, autism was originally described in the 1940s by Leo Kanner and a guy named Hans Asperger. And there's a rich history to that, but nobody knew really what caused autism for a long time. And when you have a condition where not a lot is known about the etiology, people fill in the void with whatever theory that they want. And this is Bruno Bettelheim, and back in the 1960s and 70s, he was the authority on autism, and he used sort of the latest sort of psychological Freudian psychoanalytic theories at the time to say that autism was really probably caused by a sort of a quote unquote cold parenting style. And some of you may have heard of refrigerator mothers that cause autism, this sort of cold parenting style in which parents, the only way that a child could escape this cold parenting style was to retreat into themselves in autism. Autism literally meaning folding into yourself. And so it's terrible to think, but that was the theory of autism, and parents were blamed for their autism, for their child's autism. And Bettelheim ran the orthogenic school in Chicago that would literally take kids and sort of try to cure them. There's a really fascinating study, and I've referenced this in your slide here, but around Joey the mechanical boy, who was one of his patients back in the 60s. And Joey was sent to the orthogenic school because his mother was apparently too cold towards him. And he had this fascination with levers, and he was a robot. And this is a picture of him in his bed having all these wires attached to him and everything. And of course, we see lots of kids that are, have a restricted interest in all kinds of mechanical things these days. So there's nothing really odd about this. But this was Bettelheim's quote. He was on all kinds of talk shows back in the 60s and 70s, in which he said the precipitating factor in autism is the parents' wish that the child should not exist. Just a terrible thing to think of. We think of it now in the autism world as sort of the tyranny of expertise. It's a cautionary tale that we don't know everything in medicine, and sometimes we've made some horrible mistakes in the past. And so luckily parents have sort of fought back from that. There's some wonderful stories about parents like Clara Park and Bernard Rimland and others who started parent organizations. And finally, thankfully, in the sort of late 70s, early 80s, the field of genetics sort of started making all of these advances. And this is from a paper way back in the 70s that said, wow, it's interesting that 2%, there's this 2% rate of autism in siblings, which is actually a lot higher than the general population. And that got people thinking about the field of genetics and how genes may influence the development of autism. And so this is the obligatory figure that I show you just to emphasize the complexity of autism genetic research these days. It's now believed that autism is a highly heritable condition, that there's a very strong genetic component. There are hundreds and hundreds of ASD risk genes that have been identified, and a lot of them converge on these common molecular pathways. So this shows that all of these genes that that are shown here are involved in some form of neurotransmission. So there's a lot of people call autism a connectivity disorder. This is a synapse, and all of the things that happen at the synapse to transmit neurologic impulses in the cerebral cortex, as well as other transcriptional regulation proteins. So proteins that turn on and turn off certain genes in very critical periods of neurodevelopment. So and I think what the interesting aspect of this is genetic testing has aided in the identification of autism etiology. So when folks say, well, we don't know what causes autism, that's just completely a not true statement. We know a lot about what causes autism, and yet at the same time, we're just kind of scratching the surface. And this is the time when I can pause quickly and tell you a little bit about what we're part of here at the university with regards to the genetics of autism. We're a clinical site for a national study, which is called SPARK, which is supported through the Simons Foundation. And it's the nation's largest online autism study. We're one of the 30 clinical sites across the country that are trying to recruit families into this study. And I'm now deputizing all of you as being what we call sparklers, which means that if you would please make families aware of this opportunity to be involved in SPARK. It's a really fascinating and cool study because it's very participatory. It lowers the bar for entering the study because it's done entirely online. So it's a very good study to do during the pandemic. It's really easy to register. Participants provide some basic clinical information through some questionnaires when they register, and then they're asked to consent to provide a saliva sample. So a genetic test is done off that saliva sample, ideally from the individual as well as the biologic parents, although if they're not available or don't want to, that's okay too. The collection kit is sent to their home. So I tell families it's sort of like, you know, ancestry.com or one of those things where you just get this kind of like shoebox sort of looking thing in the mail and you spit into the tube, you seal it up and you send it on back. And that's basically how it's done. Participants who register can receive a gift card to Amazon.com valued up to $50. And they may receive a genetic diagnosis. So at this time, SPARK analyzes that saliva sample. They do a genetic test called copy number variant or a microarray looking for copy number variants, as well as a sequencing test. And about 1 in 10 families actually find out the etiology of the individual's autism if one of these autism risk genes is found. So we're heavily recruiting for SPARK. We're in the 3rd year of our aspect of being a clinical site. And you can direct families just to sparkforautism.org and they'll be collected here. We have a great team, including Gabby and Heidi, who may be on the call. And you can give us a call or send us an email, and we'll always reach out to families if you want us to help them with recruitment or registering. And then to transition into environmental causes of autism, while there are no specific environmental causes that are the sole cause of autism, there are a lot of epidemiologic studies that have been done that establish risk factors from environmental factors. So just to highlight some of these, you can see that things like neonatal hypoxia, birth trauma are strongly associated with the development of autism and are a big risk factor. Likewise, taking folic acid has been shown to be protective, interestingly. And then I wanted to also highlight things that are clearly not supported. So these are the ones that have the odds ratio of 1, meaning there's no increased risk at all, and specifically vaccination. So I try to emphasize that to all providers that interact with families, because this is a big concern for families, and we want to be unequivocal in saying that vaccines are safe and effective and that there's no association with autism, which is based on, oh gosh, many epidemiologic studies. And yet it's been a little bit difficult, as we're seeing now with COVID-19. There's lots of parental concerns, and the difficult part has been is it sort of feels like whack-a-mole, where you whack some theory down regarding autism and vaccines, and then another one sort of pops up. And you have to whack that one down, and then another one pops up. So this has been happening over the last 15 to 20 years, which was fueled by a paper that was published in The Lancet nearly 20 or so years ago now, more than 20 years ago, which sort of put out this theory that the combination MMR vaccine caused autism by damaging intestinal lining and allowing these proteins to enter the body, which then migrated to the brain, which caused autism, which has no biologic plausibility and has been disproven with many studies. Once that was sort of put aside, even though there's still a lot of hesitancy around MMR, and we still see outbreaks of measles all the time, thimerosal, which was a preservative which had a form of mercury into it, must have been toxic and then caused autism. That was subsequently disproven. And now this one is probably the more predominant one that we see, in that folks think that simultaneous administration to lots of vaccines overwhelms or somehow weakens the immune system and causes autism. And there's been, again, lots of studies that have compared children who have spaced out their vaccines or not gotten their vaccines and compared the rates of autism to those who have gotten on-time vaccination, and there's no difference in the prevalence of autism in those two groups. So that's autism and vaccines in a quick nutshell. So maybe transitioning on to some of the earliest signs or symptoms, just to kind of let you know what we look for in clinic. This is sort of a quiz that I give all my learners, is what's the median age of autism in the United States? And the answer is about 4 years of age. That hasn't changed much over the last 20 years. And then the obvious question is, well, what age is therapy for autism most effective? And then the even more obvious answer is, like, if you could do it before 4. So that's the whole reason why we're trying the best we can to figure out ways to identify autism earlier so that we can get children into appropriate therapy a little bit earlier. So then the next question is, well, like, how early could you diagnose autism? And what's happened probably over the last 10 years, there's been many studies looking at younger siblings of children with autism, because it turns out that the chance of being diagnosed with autism is about 10-fold higher in a younger sibling of a child with autism compared with the general population. So what researchers are doing is essentially they put these younger sibs of children with autism under sort of a developmental microscope. They see them very often during early childhood, and they can tell then, amongst the ones who later get diagnosed with autism, how early and how exactly autism sort of unfolds. And so what, to boil these studies down into sort of an easy slide, is essentially by saying that by about the second year of life, the beginning of second year of life, it's very clear that if you compare younger siblings who go on to develop autism with younger siblings who do not go on to develop autism, that you can see differences in multiple streams of development: visual, motor, cognitive development, social communication, by 12 to 18 months. So then it becomes clear then that we could be diagnosing autism sort of at the middle to end of the second year in many children, and yet the age of diagnosis is over 4. So that gives you an idea of how much earlier we could be identifying autism. So how do you do this practically in the clinic? I mean, we're working on some of this with some Intermountain physicians right now, but this is a very easy developmental milestone that we look for all the time. So this is how it looks normally. We're working with our residents and everybody just to go in and call the child's name. And I don't know if you guys can hear this. Can you hear my audio? No, of course not. So somebody said, Kyle, and Kyle turned around. So that's basically the gist of this. And I can maybe here's what I'll do. How about this? Did you hear that okay? All right, since this is such a highly scientific thing to watch here, I'll do it one more time. Kyle. Yeah, so Kyle turns around. So that's what we see usually in clinic by the age of 9 to 12 months. It's a really easy thing to do, and yet it's a very specific early sign of autism. And so you can see here in good old Evan, who was diagnosed with autism. This is an extreme example, but give this a look.
Evan. Maybe if you can get him to respond to you now, you can use touch with his name, like give him a little tickle or something. Evan. He likes the tickles, but he's just not going to use.
So that's what we call dyadic orienting a response to name. Another sort of early milestone that we do in our evaluations, as well as what we're working with pediatricians now to do more of in clinic, is to test for joint attention. And so this is something where a child engages in another's attention to regard an object event simply for kind of sharing an experience. So this is a video showing Noelia here, who sees something that she likes in a book and she wants to share it with her mom.
You see, and the doggy is saying hi.
So you got to watch that really carefully, but
That's it.
the nice people at CDC figured that you wouldn't see that quick, so there's a super slow-mo view. So Noelia, what she does is she's reading this book, she points, and then watch where her eyes go. She points at what she likes, and then she looks right at her mom. So she's sharing this experience of seeing something that she likes, and she wants to share that with her caregiver. So that's what joint attention is. And it can be tested really easy. So you can't hear the audio of this, but there's a researcher here pointing with Evan saying, look, sorry, I'll turn this off. And Evan is more focused on her finger rather than actually watching or looking where she's pointing. So that's something that we're doing actually with pediatricians in the Intermountain system right now, is we're having their families point us things across the room during evals and just seeing if their children turn their gaze towards what the parent is pointing. So those are two early, easy to test signs in clinic, and yet it's not easy to identify children with autism in the clinic, because visits are pretty quick and there's lots of other really important things to do. And so sometimes it can be hard to find a child at that young of an age who has the early signs of autism. So back in, gosh, it's been a while, back 2007, there was a recommendation from the AAP to universally screen for autism, with the idea that we need something more sensitive where we could identify children at risk earlier. And so autism screening has been done at the 18 and 24-month visit for quite some time, or at least the recommendation has been there to do it. And it really is effective when done properly in aiding in the identification of young children with autism. We're working with a number of clinicians in town right now at our center to implement something called the POSI, which is the Parents' Observation of Social Interaction. It's embedded within the SWIC, which some of you may have heard of. And we've recently published the results of a study done through the university system, which shows that, if you do something like the POSI embed it within the electronic medical record, so that's electronically scored, and there's a cue to action for the pediatrician to say, hey, this is an at-risk score, this child should be referred, that really does help in identifying children with autism earlier. Okay, so now a child with that is found to be at risk for autism, either through early signs or screening. And then I wanted to briefly review the next step. And so we're here at the University Developmental Assessment Clinics. This is the picture of our lovely building at the Eccles Center, which is the building that's sort of stuck to primary children's by that bridge. And within UDAC, there are 3 programs: the neonatal follow-up program, there's a neurodevelopmental follow-up program for children with congenital heart conditions, and then the program that I work at is the child development program. And so we're a multidisciplinary team that does the autism evaluations when you refer children to us. So that's child development program. And just to give you an idea of what's done when children are sent to us for an autism evaluation, all of these things occur. So this, you can imagine, this is not done by one person. This is done by a speech and language pathologist, an occupational therapist, nurses, pediatricians, psychologists. It involves taking history, a bunch of measures that families fill out that are electronically scored, hearing and vision screening. All of these things are done. And then what we do after that multidisciplinary evaluation takes place, which takes place over multiple visits, is then we can compile that information so that we can apply it to the DSM criteria to either rule in or rule out autism. And so it's complicated, it takes time, it's a teeny bit messy, but it's the way we do things. There's a recommendation to do this in a team-based fashion, so that's what we've embraced. And I'm happy to answer any questions about the process at the end, but that's what you'll expect families to experience when they see us in our clinic, is multiple providers, multiple visits, and then we help and assist once the diagnosis is made in connecting to services in the community. We have a care coordinator in our clinic that helps out with that. This is how you refer to UDAC through either iCentra or, I didn't put Epic, but Epic is easy. You just put UDAC in there and we pop right up. And then of course you can do it the old fashioned way by just calling us. And then once the diagnosis is made, this is, I guess, as I told you earlier, it's generally considered to be a lifelong condition. So the goals are to maximize function, right? Minimize the challenging behaviors that sometimes occur and provide a lot of family support. Those are really the long-term goals. That's done through a number of behavioral, developmental type interventions, which I'll briefly review. Obviously, lots of children who have communication concerns see speech therapists. If there are fine motor or sensory-based concerns, occupational therapists are very helpful. If there are more gross motor or coordination issues, then physical therapists sometimes get involved. Lots of family support services through people like Utah Family Voices and the Autism Council of Utah are very helpful. And then in the medical aspect of things, we generally treat associated medical and psychiatric conditions. So while I don't treat the core symptoms of autism in my clinic, we do treat the things like anxiety or ADHD or sleep problems or gastrointestinal issues or epilepsy, things like that are far more common in people with autism compared with people without autism. So that's what we spend a lot of our time in clinic doing. I wanted to briefly review some of the behavioral interventions for autism that are available in the community. The ones that use this methodology known as ABA or Applied Behavioral Analysis probably have been studied the most and therefore have the strongest evidence base. But I want you to be aware that there are other methods that are available that have emerging evidence as well. ABA you'll hear most because it's the one that's most commonly covered by most insurers. So what in the heck is ABA? It's really a method. People use it as a noun, but it's not really a noun. So people say he's getting ABA. We wouldn't correct people when they say that, but it's really a methodology. And it's essentially a method of learning. So you build functionally useful behaviors and you reduce problematic ones. That's what behavior analysts sort of do. They use the science of behavioral analysis to improve behaviors that are desirable and try to reduce ones that are maladaptive. The focus is on teaching through lots of repetition, small measurable units of behavior that are then sort of strung together so that you can teach a complex behavior that for all intents and purposes looks fluid. It uses the principles of operant conditioning, which are really simple in terms of like all behaviors are preceded by things like antecedents. And then after a behavior, there's a consequence. And if you manipulate those antecedents and consequences, you can manipulate behaviors. So the easiest example I can tell you is that like 15 years ago when I joined the university, I was driving up Wakara dutifully to work. And there was an antecedent, which was a sign that was a speed limit sign that said 30 miles an hour. And I decided to apparently ignore it. And I drove faster than that. And I was pulled over and was given a ticket. And so that's an antecedent. There's a consequence. So if any of you are stuck behind a blue Nissan Leaf going about 20 miles an hour up Okara Avenue, that's because I've learned from operant conditioning really well. So that's what ABA is, essentially in a nutshell in terms of the principles. And I have a quick clip. So this is the very sort of earliest form of ABA. Some people think that it just involves kids at a table imitating folks, and it really doesn't. But early on, children do need to learn foundational skills so that they have the building blocks for learning more. So this is these earliest, this is just a clip from the earliest forms of ABA. This is good old Stefan. And he is in this setting where he is one-on-one with a behavioral technician who is just working on, sometimes you'll work on a new skill for a while, which can be a little bit more frustrating. And then when kids get a little bit frustrated, you'll go back to things that they know. So she's just sort of going back to some maintenance things, just making sure that he knows them. And ABA has this sort of cadence. It's antecedent behavior consequence, antecedent behavior consequence. It has sort of a rhythm to it. And so she's just going to roll through about 3 or 4 things that he already knows how to do. And he knows that if he does those things, he gets access to a preferred activity. And for him, it's the ever popular horsey ride. So you can just see what this looks like real quick.
Ready? Stefan, stand up. Let's see. Jump. Turn around. Wave. Raise your hand.
So he gets his tickles and then his horsey ride, which is, as you can tell, highly preferred. And then the process repeats. So then he'll get an antecedent and he'll do more behavior. So, early on in ABA, it feels like play, and it really is. And then as it evolves, it moves into more naturalistic environments like at the home, and we're working on more practical skills. But those are just learning some basic skills like paying attention, staying in your seat, raising your hand, things of that sort. Okay. Now, as children move into the school-aged years, many of them, I think a lot of times people in autism think like, well, there's this little window between the age of 2 and 5, and you have to do 40 hours of ABA, and then suddenly, magically, the child is transformed and everything is different at that point. And there's a lot of myths in there, and we can talk about those in the Q&A. But children with autism oftentimes continue to benefit from services throughout childhood. And so this is just a graph that just shows you that between, early childhood or the school-aged years and adolescence, many children with autism are still receiving things like behavioral therapy, OT, social skills training, which we can talk about a little bit, speech therapy, and many are receiving multiple of these therapies. So these therapies continue to be beneficial as children age. And then in terms of co-occurring conditions, this is what we do again in clinic. So while a lot of these therapies are working on core symptoms, in the school age years, a lot of these things become very relevant in terms of anxiety, depression, things of that sort, as well as sleep conditions. Children with autism are more likely to be overweight, so we think about that a lot in clinic, have GI conditions, etc. And then I wanted to maybe transition with the little time I have left into transition and adulthood. And I wanted to start off just with this admittedly long quote from the Autistic Self-Advocacy Network. And I have their website there. I think as homework, it's in this world that we live in where we're thinking about social justice and thinking about all the events of the day. I think that there's something that's called ableism that exists as well. And this is ties into the movement around neurodiversity, in which a lot of autistic adults are bringing up the fact that autism is a difference, but it's not necessarily bad or good. It just is what it is. And that people with autism benefit from not being excluded, but rather included and being accepted and supported. And so, they say this is from their website, but every person has things that are good, that they're good at, things that they need help with. There's no such thing as a normal brain. People with brain-based disabilities like autism should be accepted and included in society, just like neurotypical people. The neurodiversity movement also says that we shouldn't try to cure or get rid of autism. And autistic people should be allowed to exist, and we should work to make sure that everyone gets the accommodations we need to reach their full potential. So this is sort of an introduction into adulthood in autism, because autism, again, as I've said before, is a lifelong condition. It doesn't go away at transition age. And yet the system of services for adults is such that you might have thought that that's what we thought would actually happen, that these folks either would not be around in adulthood or that their condition would suddenly just go away. And that's not the case at all. And so there's a lot of concerning things about the transition to adulthood. And obviously, since I'm a physician, I think most about access to healthcare, which for adults with autism is not good at all. And what's concerning is that as teens and young adults enter adulthood, they're much more likely to have a whole host of conditions, especially things like diabetes, high blood pressure, obesity, all of these mental health conditions, which it turns out from the earliest sort of epidemiologic studies that are now coming out on the current cohort of adults, is that autism is likely a life-limiting condition. And so some of my colleagues are actually surprised to find out that the life expectancy of people with autism can actually be quite a bit less than people without autism. And so a lot of the premature mortality that's being reported in autism spectrum disorder is completely preventable with better access to medical and mental health care, which does not exist at present. And I think this is probably my last slide, and then hopefully we can get to some questions. So this is some work that was done by some colleagues here at the University of Utah who have been involved, like people like Bill McMahon and Hillary Kuhn and Debbie Builder, who have been involved in autism research, at least in the case of Bill, since the early 1980s. And so they went back and looked at some 25-year outcomes of people that were diagnosed here at the University of Utah. So these are 20 to 25-year outcomes. And as you can see, there is a problem with underemployment in adults with autism. Sorry, I'll make that go away if I can. Whoops. Okay, so there's a problem with underemployment. So 20% unemployment rate is much higher than the general population. And as you can see, just sort of what happens in adulthood in terms of residential situations. So about half are living with their families still. And in terms of social situation, about half are spending little to no time with peers. Now, what this doesn't tell you is what the desire is of the individual. Some people are perfectly happy not interacting with peers, but a lot of people with autism actually would like to interact and be involved in social situations, but they just don't have the opportunities. And then in terms of caregiver support, you can see that roughly, 3/4 require extensive help with social contacts, unemployment sites, economic affairs. So there's a high level of support that continues to be needed throughout adulthood. And that's something that we're going to need to really build a system for at this place. Now, I think the good news is that since I got involved in this work 15 years ago, the landscape for services for children has exploded. And so the hopeful note that I'll leave you with is that it's likely to sort of, with a lot of effort, sort of transition over to services for adults as well. So with that, I'll kind of stop because I know I want to leave some time, hopefully I did, for some questions. And I'll stop my share from there and hopefully see some of you.
Yes, hi, Dr. Carbone, this is Walt.
Hey, Walt.
Hi, two questions. One, what would be about the youngest age that you can diagnose a child for autism? And number two, how long is the UDAC waiting list to get in?
Okay, so there was a study that was put out by a colleague by the name of Karen Pierce at UCSD, and she has been doing some work with many pediatricians in the San Diego area, screening for autism at 12 months of age, and then having those children who are found to be at risk at 12 months sent to their center. So she's doing a lot of autism assessments in very, very, very young children. And she recently reported on a group that is at the 14 to 16 month age range, where they followed these folks out after diagnosing these children, and their diagnosis appears to be very stable. So that's about the earliest, is somewhere in that 1.5 year range. Now, do we see a lot of 16 to 18 months in our clinic for evals? No, not really. But screening happens at 18 months. So if a child is found to be at risk, what I see a lot in the community is like, well, we'll wait and we'll rescreen at 24 months. And that really doesn't need to be the case. If a child is screened and is found to be positive, or there's concerns about autism, even at 12, I got an email from a colleague the other day about a 9-month-old who she's concerned about autism. And we said, well, let's refer that child to early intervention. And then let's follow their development closely. And if you're still seeing sort of concerns at your next well-child visit at 12 months, we'd be happy to, start sort of the evaluation there. So that's the answer to that, is between 1 and 2 years, it certainly is very possible. And then our wait list is not between 1 and 2 years. So our wait list right now, it's a bit of a moving target, but we have done a ton of effort trying to sort of streamline the ability to get especially young children in for evaluations. And as I showed you on that slide, there's like many different steps, but our first step is a welcome intake visit with one of our advanced practice clinicians. And I don't think the wait for that is more than a month or two at most right now for young children. So we can get kids in relatively quickly. I see Athena on the call, who helped us start our clinic a while back, and I know that was a heartburn for her. But we've evolved. We have a larger team, and our capacity is pretty high right now, so we're doing okay.
Dr. Carbone, this is Pat from Select Health. Thank you for your presentation. It was very, very helpful.
Okay.
I am seeing many patients. In fact, within the last probably 3 months or so, I've had 5 newly diagnosed autistic children whose parents have reached out. Is COVID or the culture or what's happening to us changing anything that you're seeing as far as, the prevalence or whatever?
I think the most interesting aspect of the COVID-19 pandemic that we had in our clinic and in our field in general, which is just completely like a teeny silver lining to what we're all going through, is that there used to be this fixed belief in my field that it was completely impossible to diagnose a child with autism through telehealth. Like that wasn't even thought of as a remote possibility. And what we were all faced with in terms of autism diagnostic centers across the country is at the onset of the pandemic, when we couldn't see patients in person any longer, or at least we had to pause, is that we would either close, which some of us actually did, or we could just try to cope. And so in our center, I give our team a lot of credit. We decided to cope, and our psychologist came up with some really great ways that we could have observations of parents in their homes, and we have the families do some of the presses or the things that we would normally do directly with the child during an evaluation. And we can still take a developmental history. We can still collect all the measures that we do. Our speech therapists have learned how to do speech therapy evaluations online. Our occupational therapists can do the same. And lo and behold, now a year into this pandemic, we're more productive than we were pre-pandemic. We see more patients now than we ever did pre-pandemic, because we can actually be a little bit more efficient through telehealth. And we think we're giving a really great, thorough evaluation. The satisfaction from families is very high. So that's probably the biggest thing I've seen is like, wow. And we've sort of shared our results, and we're working collaboratively with a lot of autism centers across the country who are adopting some of the same sort of direct observation tools. So we're all sharing those across the country. It's been a very collaborative time in the field of autism. So that's probably what I've learned the most. And that families are really struggling with interruptions in their services, which is a really difficult thing for families of children with disabilities.
I'm just looking at the time, so it's getting close to 10. I'm not sure if the Zoom will just go poof. I don't think it will.
Yeah.
So if you have a couple more minutes, Dr.
Oh,
Carbone.
yeah, no, I'm fine. I do.
Okay.
I'm happy to stick around if there are questions. I always really appreciate your time, and I'm happy to chat.
Guys, is there anyone else who has questions? It sounds like it's okay.
It's okay.
Okay.
Or observations, or what you've learned, or needs of families that we can help with at our center, anything.
This is Gwen.
I have questions. Oh, go ahead, Gwen.
No, I'm sorry. Go ahead.
No, you're good.
Sorry, this is Gwen, and I work for Children with Special Health Care Needs Integrated Services Program, and I cover Carbon, Emery, and Grand counties. And I recently got to work with our San Juan coordinator.
Great.
I felt that Grand and Emery were pretty remote, and once working with San Juan, I found out, I had no idea what remote really was. And we're, trying to refer to UDAC, and we've had a pretty great relationship. I feel like the team there has been really great at helping us send referrals over, but we're still having, I think, some technology problems. We're getting referrals from your team to help facilitate electronics, which has been great because we got a grant to do that. But I think there's still some unique situations that are done individually, and I'm just not sure what would be the best way to approach that. And I think sometimes our wait list ends up being a little bit longer, and I think that probably comes with the influx that you guys are getting, and just if something more specific that we need to do that can help move those faster.
Yeah, well, you're legendary around our clinic. You have a lot of respect. Everybody, all the team really respects all the work that you've done down in Grand County and where you work. Yeah, we've been interested in sort of equity in terms of ability to access autism evals, and so the ability to do them through telehealth we thought would be, bring the bar down a lot in terms of access. But I think, as you suggest, it's, if you don't have a broadband signal, it's sort of hard to do a telehealth evaluation, and a lot of times families have difficulty with transportation. So if it was easy, I think these problems, we would have solved them a long time ago. But I think we've made some headway, and we always just want to probably, I could say, I know you've been working closely with folks in our clinic like Sylvia and Claudia, and we just want to hear about what your challenges are so that we can do whatever we can to accommodate families, to evaluate them sort of in their communities. I know that we've reached out to, in San Juan County, to the Navajo health system down there, Val Jones and his group, and we're planning on doing some outreach to providers in rural and underserved areas, like through the community health centers, et cetera. And I'm hoping that will help. The idea that some folks around the country have had is, could we train local pediatricians to have enough expertise in autism evaluations where they could apply the diagnosis so that kids could get access to services, at least in the children who have sort of unequivocal symptoms of autism. And a lot of times the tool that's used is called the STAT. And we're going to be working with several pediatricians around the state to see if we can sort of scale up that system so that there are local folks when things like, I think what you're alluding to, where it's just going to be really hard to get the family up to Salt Lake or do the eval by telehealth. And I know your team also has folks like Cynthia who can, and Natalie who's on the call, who go down to those areas. So those are also options. So hopefully we're filling in the gaps as best we can, but we're always looking for feedback on how we can do things better and how we can support you.
Thank you. We probably have a lot of ideas. So as we staff amongst our remote areas, it might be better to have just one person like Natalie report back as opposed to all of us. So we can work on that in our stuff. But we do appreciate this, and our families are so grateful, and that because you used to travel and probably still do, but our families are very grateful for all the help they get.
Well, thanks. Cindy, did you have a question there?
Yeah, my question is probably threefold, if you could entertain that.
Sure.
First of all, are there certain children that absolutely need an in-person evaluation? I have a couple of kids that are, sounds like we're ending up with some hearing loss, and parents are insistent that your evaluation be in person. The second question has to do with, is there any insurances you are not able? I know that as I refer there occasionally, I'll have a parent say, oh, they can't work with our insurance. And if you're not working with insurance, what may be a cost for someone with a high deductible? And then my third question is about follow-up. I know you give patients resource, but it would be really nice if we could somehow seamlessly work with the University Developmental Assessment Center on children who are diagnosed, so that we can start taking over and following up on those resources rather than working disjointed and independently from you.
Okay. So there are children who we see who, for a variety of reasons, we think are just need an in-person evaluation. And so we are working in person now. We're sort of transitioning back to clinic. I think the hard part early on in the pandemic, and that still exists now, is that some of the diagnostic tools we use, like when you have a mask over your face, you can't see facial expressions very well. And so they're not validated to be used with, like all this PPE on. But I think we're able to get around that in some ways. And so, some families just prefer an in-person evaluation, so we can accommodate there. Other times when the technology isn't such, like sometimes you're on an iPhone in somebody's house and it's jumpy and the connection's terrible, and after 2 hours of that, you can't make a call. And so sometimes it's just better to bring people in. And then there's other cases where the symptoms, maybe we have a good connection and we have a good visit, but the symptoms are still subtle enough to where we really feel like we just need to get in the same room with the individual and have more time. So those are probably the examples of when we still do need to sometimes do in-person evaluations. So I hope that gets to that. And then something that I'm not great at is insurance, but I'll try to answer that the best I can. We've worked pretty hard, and I'm talking about our administrative team, to take most insurances. So almost half of the families we see have Medicaid, and we take Medicaid. So we're really, I'm exceptionally proud of that. We also take most other private insurances. So we've added Select Health recently. I'm not aware of too many that we don't take, to be honest with you. And then, and with high deductibles, that's sort of a bummer. I'm one of those guys that, I always thought that having a high deductible health plan was never a great idea. And this is probably another reason for that. But if there is a high deductible, the cost of doing these evals, and you can see all those components that we listed, it turns out to, like, when you have to, like, we have to pay our speech therapists and our occupational therapists and our psychologists and our developmental pediatricians and our nurses and our MAs. And so the visit can cost on the order of thousands of dollars. Like, that's just what insurers get billed. And so if there's a high deductible, that can be problematic for families, we know. In those cases, we can definitely recommend other providers who don't do like multidisciplinary evals that may be able to do it a little bit more on a cost-effective basis. We can do that. Families I know that don't have insurance can work directly with our university medical billing for, discounts on being self-pay, things of that sort. So in those cases, I always refer them to our administrative team, who can put them in touch with the right people to see if we can make it a little bit more cost-effective for them. And then I'm not sure how to answer your last one. We do have a care coordinator here. The navigating services for autism in terms of getting access to ABA can be tricky in terms of all of the myriad criteria that insurers sort of need to have all these boxes checked in terms of the components of the evaluation so that kids can get access to ABA therapy. And so we work directly with families, our care coordinator does, to make sure that all those boxes are checked, that there's a letter of medical necessity, sort of a prescription for ABA that we generate. And so we do that all directly with the family. We send all the documentation to the medical home, but I'm always interested to hear how we can partner a little bit better. We've taken the approach of trying to work directly with practices right now. So maybe one example is we have this system that we're calling Aspire, where we're trying to make the system a little bit more dispersed throughout the community. And we're working with primary care practices to educate pediatricians and folks who work within practices to better support the needs of people with autism in the primary care setting. So we're working on things like autism screening and creating those ways to have pediatricians trained on the stat, for example, things of that sort, so that we're kind of sharing the workload to make things easier for families. But in terms of care coordination, if you have any ideas, like, we're all ears.
Thank you. I'm not sure if I have ideas on how that can happen better, but I do know that often when I've had patients that have been evaluated there, then I don't know exactly what they've been directed to through the university. Sometimes even getting those evaluations back it's been quite difficult if the parents forget, even though that we referred to sign releases. So I think primarily just if we were.
Yeah, gosh, I guess maybe in that case, giving us a call, because the notes that we have should automatically be sent back to the referral source. So you should all be getting those. My wife is a general pediatrician, and she oftentimes complains that she gets too much from us. So I know that they should be getting there. If they're not, though, please let us know, because it's not our intention not to withhold that information from you. We want to get that information to you.
Hey, Cindy, this is Heidi with UPIC. I'm just wondering, what organization are you with?
I'm with Wasatch Pediatrics.
Okay, so even when I was a care manager at Redwood, a lot of the notes would go to, and because we're University of Utah, they would go to like Dr. Whittemore, and so I would never see them as a care manager, but I would still, because some of these families are notorious for just not, missing the call or not going or whatever. But unfortunately, I would actually have to call Sylvia. Not unfortunately, because she's an amazing case manager with UDAG. But if I gave her my information, she would always call me and say, hey, they are scheduled at this day. And then if they didn't show, she would call me back and say, they didn't show. And then I would call her and just say, okay, what was the, I can't get Dr. Whittemore to like give me the notes. What what, what interventions, what are you referring, what is that? And she would always give me, she would PHI me, email me the note itself. Sylvia, the case manager there, she's awesome. And she's really good at following up. So maybe just having her contact she won't get back to you like within 5 minutes, but she usually will get back with you in the day. I've never had an issue.
This is Janelle from, I'm Intermountain Pediatrics Care Manager. I was going to mention that we have a read-only Epic access, and through some learning and over time, I've been able to, it's actually quite easy to find the information, the notes, and then you can also look at the referral status. And if the referrals, because that's been kind of our issue, is making sure that the referral's been received and that we are actually on the wait list. And so without having to make a phone call, because the phone calls can actually be, a day back before you can get back, they can get back to you, you can actually request that access. I think that these other care managers maybe need that information, that they can, how to access this information.
I will tell you that Epic is a little, for some of these smaller organizations, not like Intermountain, sometimes they don't like to, but the other thing too is I believe they are part of the CHI. So Cindy, I don't know if you can get your organization with the CHI that talk to each other, that might also help.
We don't have CHI, but maybe I can manipulate Epic just so that I can see the status of the referral, because yes, I am the middleman between those referrals, calling the parent, calling UDEC, and I just feel like it's just not very seamless.
It's not working.
And it's nice to have Sylvia's contact information. That's a good one for me.
Just as a backup, so.
Yeah, if you give us a call at 587-2255, that's our number. And we can definitely, Cindy, get you sort of the bat line for Sylvia. And so that you can kind of have some direct contact with her. So just give us a call and ask for Sylvia, and she'll introduce herself, and we'll see if we can create a connection there with you. That's sort of the easiest way. And I agree, when you're across healthcare systems, it gets really difficult to transmit stuff. And I know that things like the CHI can help, but maybe just having that personal connection can help.
Okay, well, I am afraid I'm going to have to call time, guys. But thanks to everyone who stuck around. Clearly, lots of questions around this, and such a great resource in Dr. Carbone. We thank you so much for coming. We do have your presentation, and I'm sure we can reach out if there are further questions. This is really interesting. We'll try and make sure that we're clear as we get the notes out about requesting Epic, but also being able to follow back up with UDAC by phone for questions and more information, and even mention the CHI. Sounds like it might be a future meeting topic there on the electronic stuff. So, all right. Well, thanks everyone so much. We meet again on May 19th, I believe, and I think we might be getting a COVID update around kids from someone in the Department of Pediatrics at the U again. So we love our experts. Thanks everyone. We'll talk to you later. Have a great rest of April. Bye-bye.